Well, a very good afternoon, everyone, and welcome to today's Hopkins Hour for the seminar, The Importance of Adherence and Peer Support in Chronic Pain Management. I hope that everyone can hear me. We just resolved a few technical glitches, but I think we're good to go. We would like to extend a warm welcome to all Hopkins Center members, partners, and collaborators who are joining us today. Can we have the next slide, please? Before we begin today's presentation proceedings, I would like to acknowledge the traditional owners of the land on which we meet virtually today. My work office is on the land of the Jagera and the Turnbull peoples, and I would like to pay my respect to the elders past, present, and emerging. We encourage all attendees to research and connect with the traditional owners of the land on which they live and work. Can I have the next slide, please? For people who do not know me, I'm Michel Coppieters. I'm Professor of Musculoskeletal Health and Persistent Pain at Griffith University, and I will be the host of today's online seminar. Before we get started, a few housekeeping items to address. Internet connections will vary in this online and stormy environment lately. So if you experience technical difficulties, please feel free to put a question into the chat, and one of our event team members will be able to assist you. If needed, you can leave Teams, the platform, anytime you like, and you can return to it, and you shouldn't have lost your place. You can turn on captions via Teams meeting settings. If you click the three dots on your toolbar, and then select language and speech, and then live captions, you will get captions of what we say today. Please use the chat function to ask questions at any time throughout the session. From the top level Teams navigating bar, select chat, and this will open the panel on the right hand side of your screen, where you can type your question or discussion item into the type a message box. Today's speakers will answer as many questions as possible during the session as time permits. Any questions that we don't have time for, we will share responses after the session. So during today's session, you will hear two presenters about the challenges of managing people with persistent pain and two novel approaches that are currently being trialed and evaluated. So today's presenters are myself, and I just see that my camera was a bit blocked. So myself, I will present the results of a multi-center randomized clinical trial that compared a blended intervention. It is eHealth and in-person physiotherapy with usual care physiotherapy for people with persistent pain who also have psychosocial risk factors for recovery. Jonathan Dearness, who is a senior physiotherapist at the Gold Coast University Hospital and also a PhD student at Griffith University, will be the second presenter, and he'll discuss biopsychosocial group interventions using expert peer patients as facilitators as another approach to the management of people with persistent pain. He will present the patient's experiences with these innovative principles as currently implemented in the Uplift program. And the paper that Jonathan will be discussing today has just been published, so congrats, Jonathan, on your first PhD paper, and we will share this paper after today's Hopkins Hour presentation. As I mentioned earlier, following Jonathan's presentation, there's time for questions. But if you like to put questions in now, feel free to do so. And let me then get started with the presentation. Can I have the next slide, please? All right. What I will be presenting today is the results, basically, of the Back to Action cluster randomized clinical trial. And this is a trial aiming to improve the condition of patients with spinal pain, so back pain and neck pain, who are at risk of having a poor recovery. Next slide, please. And what I'll try to explain to you towards the end of the trial is that adherence to these programs matter. So if we start diving into psychosocial risk factors in people, it is important basically that they continue the intervention and don't stop halfway, because it might harm is maybe a big word, but it might impede their recovery. Whereas if they adhere to the program, their results will be a lot better. But I'll come back to that at the very end of my talk. Next slide, please. All right, let me set the scene first. And as you can see here on the right-hand side, a paper that was recently published, looking at the prevalence of depression and anxiety among people with chronic pain, you can see that 40% of the people experience depression and anxiety. And that is in a chronic pain population, and that is much higher than in their peers, both in clinical and non-clinical situations. So the prevalence of these comorbidities is quite high, or is very high, I should say. Click, please. Thank you. Now, this is important as we know that psychosocial factors such as depression, anxiety, fear of movement, pain catastrophizing, etc., they hinder recovery and they might facilitate the transition from acute pain to chronic pain. So these are important factors to target. Next slide, please. So 40% of the people have it, but if you look at the orthopedic literature, only 9% of the trials include at least one social determinant of health. Only one. Next click, please. And only 1% of these trials actually include a social determinant of health in the analysis. So there seems to be a huge discrepancy between people having psychosocial risk factors and then psychosocial risk factors being investigated in orthopedic clinical trials. Next slide, please. So we know that they're important, but we also know that a lot of health clinicians, OTs, physios, etc., feel unprepared to assess and manage psychosocial risk factors. And this is an editorial that was published a little while ago, or earlier this year, I should say, by Michelle Sterling, who said, like, physiotherapists generally receive only limited education in delivering psychological care and consistently report a lack of skills and confidence to incorporate psychological care. So it's important, but many of us feel most comfortable still in this biomedical world, and we have difficulties addressing psychosocial components. Next slide, please. So what the editorial also states is that we need to provide support or training for clinicians. They're interested, but we need to provide them with support or training to do better in psychosocial management. The way we tried to support clinicians was by creating 6 online eHealth modules, specifically targeting pain science education and behavioral activation, specifically for people with persistent pain. And the research question that was a bit quick, but you can go back to thank you. So the research question we had was like, what is now the added value of these online modules for patients in addition to standard physiotherapy care? So in-person physiotherapy plus eHealth modules versus in-person physiotherapy by itself. And in both arms of the trial, the physiotherapy was more or less the same. At least it was in line with international guidelines for the management of low back pain and neck pain. Next slide, please. And this is what the intervention looked like. So it was a 6 weeks intervention, and the people in the experimental arm received, or they could unlock one of these modules once a week. So every week, basically over that 6-week period, they could unlock one of those modules. And they were about understanding pain, feeling safe, feeling balanced about their story, feeling motivated, and then future goals. And if you can see that the bottom right corner there, we try to make these as palatable as possible. I'm not sure if we 100% succeeded. It was a combination of written information, patient examples, videos, tasks to identify personal factors, quizzes, activity, scheduling for value-based activities, pain and mood diaries, etc. And the idea was that it was a truly blended intervention. So the idea was that the online modules would be blended with physiotherapy, with the in-person sessions. So what do I mean with that is that the clinician who was treating the patient had insight in the modules and the task that the person completed. He or she was supposed to ask about how things, if the person understood what was mentioned in the modules. And so the idea was to have a real deep interaction to improve deep learning of the patient. And as I mentioned, then the physio sessions were in line with clinical guidelines, advice and education, exercise, mobilization, and behavioral therapy. Next slide, please. For those who want a little bit more information about the actual trial, so we've written everything up in the protocol paper that was published a couple of years ago. And if you go to the next slide, The reason why I show it to you is because it also has the curriculum in it of these online modules. And so the 6 modules are there with the target concepts, how it was delivered and how it was evaluated. So it's an open access paper, so you can just download it for free. If you type in back to action and my surname, it should show up. Next slide, please. So who were the people in the trial? They were people with low back pain and or neck pain of at least 6 weeks in duration. And they should have, on top of that, at least 2 risk factors for poor recovery. And we define them as mild to moderate depressive symptoms, mild to moderate anxiety symptoms, or pain-related fear of movement. So we didn't want them to be clinically depressed or clinically anxious. So there was a lower threshold they had to get over, but they couldn't be too high either. So there was a maximum threshold as well. And I'll come back to that in a minute as well. Next slide, please. So what were the outcomes of interest? It was disability, and for the musculoskeletal clinicians amongst us, it was the Oswestry Disability Index for back pain and Neck Disability Index for neck pain. And then we also asked them about the overall effect. So compared to baseline, how are you at 2 months, how are you at 6 months, and how are you at 12 months? And then they had a choice of 7 answers. Completely recovered and much improved was considered as an improvement. Anything below that dotted line was considered as they're not improved. Next slide, please. Then we had a whole series of secondary outcomes. Pain intensity is an obvious one. Then depression, anxiety, and pain-related fear. Again, they're related to the inclusion criteria. Pain catastrophizing, self-efficacy, pain knowledge, and quality of life. So quite a few outcome measures. And as I mentioned earlier, they were measured at baseline, at 2 months, at 6 months, and at 12 months. Next slide, please. For the statistical diehards amongst us, how did we analyze it? With multi-level linear mixed models. And we did the analysis with and without confounders being sex, age, pain intensity, depression, and anxiety. You can forget that for the presentation, but what I would like you to remember is that we did 2 types of analyses. The first one is what we call an intention to treat analysis. And what does that mean is that you basically analyze the results of people depending on what intervention they had prescribed to them. And so they were either prescribed the online modules and physiotherapy, or they were prescribed physiotherapy in isolation. Yeah, regardless of whether they did this intervention or not. And let me compare it with an exercise trial. If you compare and say like, okay, I'm going to compare people who exercise versus people who don't exercise. Not everyone does their exercise, of course, and there might be many reasons why people decide not to exercise. Well, in an intention to treat analysis, you ignore whether or not they did the exercises, but you're looking at those people who were prescribed exercise versus those who were not prescribed exercise. In the per protocol analysis, you do things a little bit differently. So then you look at, okay, we acknowledge that not everyone likes to exercise or is in the capacity to exercise, but let's now look at the results at those people who actually did exercise. Okay? So for example, if you say 6 weeks, once a week, Monday to Friday, 30 sessions, we can say, well, at least people who exercise 20 times, we're going to consider that they did the treatment. Yeah, so that's the treatment per protocol. So for our intervention, we defined per protocol as that they had to complete at least 5 of the 6 modules. So people who did 1, 2, 3, or 4 modules were not considered in the per protocol analysis. Okay? They didn't do their exercises, so to speak. All right, I'll talk about intention to treat first. Next slide, please. This is how we ran the trial. So we recruited primary care physiotherapy practices. There were 42 practices with 20 practices delivering the experimental condition, so including the online modules, so the Back to Action program, and 22 practices delivering the traditional in-person usual care physiotherapy. 66 therapists for the experimental intervention, 57 volunteered for the control intervention, or were allocated the control intervention, I should say. However, some of them lost a bit of their enthusiasm, as you always have in research. So not all practices actually recruited patients. And so 17 out of the 20 for the experimental condition and 19 of the 22 for the control condition. So if you look at potential participants, roughly 200 and 171 for the two arms. Not everyone met the criteria, of course, but what I like to point out is that in the experimental condition, 29 people actually scored too high on psychosocial risk factors. So they were clinically depressed or clinically anxious, for example. And in the control condition, it was 10 out of 171. So although they attend a physiotherapy clinic in primary care for a musculoskeletal condition, some of them should be referred on and are not suitable for intervention programs like these. That left us with 87 people in the experimental condition and 56 in the control condition. We had quite a bit missing data, I have to acknowledge, and then we analyzed them at 2, 6, and 12 months. Now, if you add up the numbers, we had 143 patients in the trial. We had to finish the trial early. We had aimed to recruit 202 people, but with COVID, with other reasons, etc., we simply had to, we ran out of funding basically. So we had 71% people in the trial of the number that we actually needed. Yeah, and I'll come back to that in a second. Next slide, please. All right. The remainder of this talk, I'm going to try to bring these slightly boring tables to life. And unfortunately, I don't have a pointer here, but I made a few arrows so you can see it. So these are the primary outcome measures. Remember, disability and perceived recovery. Now, if you can read it, I hope the screen you have is big enough. You see baseline, 2 months, 6 months, and 12 months. So that's the individual for the individual time points. And then the overall treatment effect is basically the combination of these 12 months, these time points over 12 months. Click, please. Thank you. So if you look at disability, you see that if you look within one treatment arm, right? So the B to A means back to action. So that's the online modules. The score decreases from 16 to 11. Right? So they're less disabled. The same for usual care. They go from 15.6 to 10.7. And so they are less disabled at the end of the treatment compared to baseline. If you look then underneath that table, it says the minimal clinically important difference for a treatment is, on average, people say roughly 20%. So if you, for a physiotherapy treatment, have 20% reduction in symptoms, most patients will say, look, I thought it was worthwhile, 20% or larger. Some people are a bit more strict and say it has to be 30%. Yeah, but 20 to 30% is kind of the norm. That is within one treatment. Yeah. For between treatments, that difference can be smaller, of course, especially the treatments are very similar. So if you compare one physiotherapy treatment with another one, consensus is that one treatment, before you implement a new treatment, it has to be roughly 10% better than the old treatment. Yeah, of course, cost will depend and time commitment, etc. But for within physiotherapy treatment, that's often not too dissimilar. If you, however, compare surgery with physiotherapy, for example, two active treatments as well, you may want to have bigger treatment effects of surgery, for example, because it's invasive, more costly, more recovery, etc. But so for us, the magic number is roughly 10% difference between the two interventions is by most patients considered clinically meaningful. Can you click on the clicker, please? Yes, thank you. So if you now look at the relative difference for disability, at 2 and 6 months, it is 11 and 18% difference in favor of the online people who receive the online modules. However, if you click again, please, if you look at the statistical differences, then these differences are not statistically different. So there's no statistical difference between the two. Now remember, we only had recruited 71% of the people in the trial. If you have fewer people, it's harder to reach significant differences. Yeah, but that's not the explanation, I think, why this is not significant. It's simply not, the difference is simply not too big enough and too varied. The story is not better for perceived recovery. The differences, again, 13% at the end of the trial, 13% at 6 months, but 3% at 12 months. And very appropriately, we weren't too pleased basically with these results. We were a bit disappointed, I'll be honest. You want to see big differences, and we didn't see them. We saw some differences, but not much joy for the primary outcome measures. Next slide, please. Things start to look a little bit better for some of the secondary outcome measures, but they're secondary, they're not primary. Although pain is of course important for people who come to a clinic for back pain or neck pain. Again, you see clinically meaningful improvements within a trial arm from 6 to 3.6 on a visual knock scale from 0 to 10, and the usual care from 6.4 to 4.4. So differences, improvements 19, 26, 18%. So a little bit better. And now we start to see significant differences between the two treatment arms in favor of the people who did the online modules. One thing that was very different was their understanding of the level of pain. So if you give people traditional physiotherapy, they have some improvements, but not too much about what pain really means. But if you target this with online modules, it really makes a difference. So clear significant differences there. Next slide, please. Very mixed results for the psychosocial factors. Kinesiophobia, we see significant differences between the two arms in favor of the Back to Action program again. Nothing for self-efficacy, nothing for pain catastrophizing, and alarm bells should go off. We see that people in the Back to Action group, where we start talking about basically psychosocial risk factors, etc., they have a worse recovery than people who are in the usual care arm, which is a bit more biomedical. Not purely biomedical, but a bit more biomedical. So us talking about it, or the clinicians talking about it, seem to have waken up the beast, basically, but it didn't tame the beast. At least if we stay with the intentional treatment analysis. So yeah, that was a reason for concern. Next slide, please. For quality of life, no major differences between the two treatment arms. So overall, somewhat disappointing for all the time and energy we put into this trial. But next slide, please. Next click, please. So let's now look at the protocol analysis. So 50% of the people did 5 or 6 of the modules. 50% didn't. So if we now look at the 50% who did the modules, so who adhered to the program, things look a lot better. So basically, for disability, there are now overall improvements and statistical differences between the two treatment arms. People who received the online modules had less disability than people who didn't. Perceived recovery, at the end of treatment, there you see one statistical difference. Might be coincidence as well. Next slide, please. The differences we already saw were much larger in the per protocol analysis for pain reduction and for knowledge of pain. And so the percentages improvement and percentages difference, I should say, were becoming quite large. So that's good news. Next slide, please. Here for the psychological factors, there's also much improvement here. So again, for kinesiophobia, the improvements become larger. No change for self-efficacy. There is now a significant difference for pain catastrophizing. And where people, the whole group in the intentional treatment analysis got worse overall, or no, I shouldn't say got worse, didn't improve as much as the control group, that difference or that negativity is now completely gone, with one statistical difference in favor of the Back to Action group. It's still a bit disappointing here because we would have, when we designed it, we thought like that people would do much better on depression and anxiety. Now looking back at the modules is that we probably didn't target this as much enough. To address it basically, we raised it and we brought it on the attention, but the focus of these modules were mainly pain education and behavioral activation, and not so much against depression and anxiety. We do know, however, from the psychological literature that online interventions for depression and anxiety are highly effective, equally effective as face-to-face consults. So next slide, please. So, okay, sorry, this one, no difference for quality of life in the per protocol analysis. Next slide, please. So conclusions, patients improve in both intervention arms. For the intention to treat analysis, there were some modest differences between two interventions, but for the per protocol analysis, so where people basically adhered to the intervention they were supposed to do, there were substantially larger differences between both interventions, indicating the value indeed of these online modules. Now Pardon me. We still have some work to do, of course, because only 50 of the participants completed the online modules. Some people had a quick recovery and said, I'm out of here, I'm gone. But a lot of them, of course, didn't find them engaging enough to continue, etc. So we have some work to make these modules more engaging. We're currently reviewing them before really implementing on a wider scale. And we're also changing them to better address the psychosocial risk factors and not just make people aware of it, but try to offer solutions maybe on the field of depression and anxiety. And that brings us to the end of my presentation.
Just for our attendees, Jonathan was connected and we did have audio, and then just as we were about to start, we lost him and we couldn't hear him. So if anyone has any questions for Michel, maybe now would be a good time to put them out there.
More than happy.
No questions currently.
There's a question from Hannah. When you run a protocol analysis, how much does that then impact your sample size? Yeah, that is, of course, a limitation of per protocol analysis because you further reduce your sample size. And that's why we're not only looking at statistical differences, but you're also looking at the treatment effect sizes, etc., which especially because we didn't, even in the main analysis, didn't have enough, or we didn't reach our sample size calculation, which was 202, we had only 143. So yeah, that already impacts a little bit on your chances to find statistical differences. And of course, then in the protocol analysis, where another 50% of the intervention group was removed, makes it harder to find statistical differences. But stats is not everything. And the treatment effects, the percentage differences are often more meaningful, or they're two different things. So it's definitely worthwhile just to look at effect sizes and percentage differences between the two groups to get a bit of an idea. Luckily, the experimental group was larger than the control group. So even reducing that to half still left us with 40 plus people. All right, anyone with other questions before we try Jonathan? So Tim's question, what's the next step? Well, the next step is that we're currently starting an implementation study and a cost effectiveness analysis, where there is some cost, of course, associated with online modules. It might take a little bit more time for the clinician as well. We would have expected maybe that patients in the experimental arm would have less treatments than in the control treatment, and that was certainly not the case. It doesn't make the rehab quicker. It doesn't replace the physiotherapists. What we need to do now is look carefully again with new insights as well, because these modules were developed quite some time ago now, update them with newest insight in pain education. But mainly, I think, is we had psychologists helping us with developing the modules, but it would be more like involving them even more for some of the psychological factors, which we clearly opened up basically the can of worms, but didn't sufficiently address it. So that's something we need to do. Yeah, so the next question is why were some people not adhering to the program in full? We have done a qualitative study amongst both therapists and clinicians. Clinicians and patients with their experiences with the program, but I can't remember by heart what the real reasons were. So I really can't answer your question, but I can see. I think one of the two papers has been published, so I can send it to you, Sarah, and then there might be some reasons in there. There probably are in both directions. That people get better quickly, and some people might have only had 6 weeks of pain and they recovered quickly, and they're not able to come anymore. it's in primary practice, so the threshold to attend is reasonably low. It was reasonably nearby, so there were quite a few practices, although some of them probably still had to drive considerable distances in less populated areas. And the other reason, it was not engaging. Every module was roughly 45 minutes, so it asked quite a bit of extra commitment from the patient. And some people are a bit dismissive, of course. You come to the physio for a musculoskeletal problem, and you expect a biomedical approach, and you don't expect that your physio maybe starts to addressing some of the psychosocial factors. So it might also be that there's still a mismatch between some patients thinking like, well, hang on, it's not between my ears. Why are you not treating me in a biomedical way? So that might be another reason. There's probably a whole series of reasons.